Good afternoon, everyone. I think we'll go ahead and get started in an effort to keep up the frenetic pace of the VEITH Symposium. We'll be doing some rapid-fire talks here. We're super excited about it. I want to just introduce the panel. So my name is Peter Schneider. This is Anahita Dua from Mass General, Ted Gifford from Hartford and University of Connecticut, Mike Sia from UT Southwestern, and Dr. Raman Sharma from Mount Sinai. So top stars, up-and-coming stars. And I'm just going to kind of give a little intro here about what we're talking about. So if, during the course of the last couple days and the next couple of days, you're going to hear a lot about vessel preparation, a lot about how to create a lumen very well so that our definitive treatments work. And that's really what we were thinking about when we went down the road of serration technology. And the key thing about serrations is they're everywhere. They're in every industry. They're in every home-made device you have. They're in your FedEx box where you have to unzip it along the pre-specified line because of specific things that have to do with physics. So here's just an example of a mild-mannered quarry man who's going to split a 26,000-pound granite rock. And he doesn't take a sledgehammer. What he does is he takes some little wedges and does a tap, tap, tap along a specific line. And suddenly now you have this seemingly immovable object now starting to split in half. So what would happen if we applied that same concept to angioplasty, to lumen creation, to the work we do on a daily basis? But we also made it simple, made it user-friendly, and made it something that was easy to incorporate. So if you actually do the math, what you see is that for other types of modified balloons, here are just a couple of examples, that you can increase the force of a modified balloon by putting a wire or another device on the outside up to 20 times or a little more what you can get from a balloon. But with point force technology, which is kind of taking it a step further than focal force, you can get 1,000 times. So another way to think of this is that if someone steps on your foot wearing stilettos, it feels really different than if that same person steps on your foot wearing Keds. And so using this point force concept, what we've done then is kind of validate this. Here are some OCT and IVUS studies by Dr. Holden and Dr. Nowakowski from Poland, Dr. Herdig from Germany. So we've been to multiple sites around the world. We've repeatedly demonstrated this concept of the creation of serrations and the ability of the artery to expand along that line that was created by the serrations. And here are just a couple of cases here of lumen creation. And then lastly, we have looked at Serenator plus DCB versus prepping with POBA and then followed with DCB in a preclinical model and found a dramatic increase in drug uptake with Serenator preparation. So the concept of creating serrations, like I said, it's in every industry. We need it in our work in the infrainguinal and peripheral arteries. And the clinical evidence is shown here with reduced residual stenosis, reduced need for scaffolding with high levels of freedom from CDTLR and increased drug uptake. So with that, I will just introduce Anahita, as I said, from Mass General, and please take it away.
Thank you very much. Thank you. Welcome, everybody. I'm so glad that you're here. This is basically the start of, I think, a new era. As we were just discussing, having serrations in plaque is something that can really be revolutionary if used the correct way. But before we start talking about what the future holds, it's important to talk about why. Like, why are we doing this at all? There are many cool ideas, but are they really impactful? And that's what I really want to kind of set the stage for. So let's talk a little bit about below the knee. Of course, this is a national, international meeting, so there are people from all over the world, and of course there are different opportunities for below the knee care in different parts of the world. But for the most part, we really don't have anything that works in this space. So why is that? Well, let's start out with what's going on in the world. this represents our community, and that Godzilla represents diabetes. So there was a very famous quote by a guy named Jocelyn, who was a doctor who took care of a lot of diabetic patients many years ago. And what he said famously was that the era of coma has given way to the era of complication, which meant that now with insulin, patients are living with diabetes, and now we're seeing all these new complications that we'd never seen before, and for that we need new strategies to handle them. Diabetes is increasing across the planet, regardless of whether it's a first or third world country, and by 2045, pretty much 1 in 3 people are going to have diabetes that's going to be really affecting their microvasculature. And why do we care about that? Well, because it changes the game a little bit. It used to be that, hey, there's a one tibial lesion or one SFA lesion and we can do a bypass and that's the end of it. And that's not the case anymore. Trying to get great inflow so that you can heal those wounds that are very distal is really important. And it's not so much how durable, like how many years this is going to last, but rather how long your segment is going to stay open for so that you can heal that wound or deal with that rest pain. And with microvascular dissemination, which is resulting from diabetes and the loss of blood flow in the foot, what we're seeing more and more, as you all know anecdotally, is amputations. And the shift has gone from the SFA kind of big lesions to always now the tibial and below. And yet, there's not really anything in this toolbox for the patients that we're seeing. So if you look at this slide, I've just broken it down by above knee technologies and below knee technologies. So for above knee, we've got a lot of stuff. Why? Because we're catching up with that disease process. We've got angioplasty, arthrectomy, we've got stents, of course, we've got drug-coated balloons, and we've got decent results. And we've, of course, got our fem above knee bypasses. But when you're talking about below the knee, certainly in the US, really other than angioplasty, you pretty much don't have anything that's accepted. Even in the arthrectomy space, there's a lot of controversy about that, which we all know. Reimbursement differences, different in people's hands. And so how do you get that luminal gain where you don't cause embolization, you get just enough that you can go and deposit drug, and you do something that preps, again, that's the right word, your vessel, such that you can actually have a durable result in that space and the wound can heal. And right now, frankly, there is just nothing. There's many things on the horizon, but nothing that actually we have in our hands. And why is that important? Well, because patients get amputated. If you have a patient with a bad wound, even if you go and do some POBA, right, and you get a good angiographic result, what ends up happening over time is that's now going to stenose down. And if your toe pressure is hitting 55 and allowing you to potentially heal that wound even with POBA, as that vessel starts to stenose down, that number, that toe pressure is going to decrease more and more, and your wound is going to start to reverse in its wound healing, and ultimately the patient will get amputated. And why do we care about that? Well, we all know that 50% of the patients who are amputated with a major amputation are dead within 1 year of that. So naturally, that's not because they just got amputated. It's an indication of what's going on with the disease across the body, and that's why my colleagues are going to be talking a little bit about how this can be used in different beds. But the point is that having something that's going to allow good blood flow, keep that leg on the patient's body, allow good wound healing is paramount, and we need it for the below knee space today. Actually, we needed it yesterday. I am the national PI for the Clarity study, which we just presented a day ago, which is basically a study looking at the natural progression of critical limb ischemia in patients across the United States. Because while we know the amputation rate is high, we don't actually know who's doing these amputations, what patients are getting amputated, why they're getting amputated. And so I only bring that up to tell you that in presenting our data, what we found is that of the 180 patients that were enrolled, we had 66% of them falling into the, quote, no option group, as in there was nothing that could help them in the below the knee space. And so once again, that affords an opportunity to try to save those legs with different types of technologies that are not going to hurt the patients and can really only help. So at this point, we have, all of us, anecdotally in our bank, patients that have tibial disease, pedal disease, where it's hard to cross, and even if you do get across, some of the other technologies are too bulky to actually treat. And so having something small that's going to glide into that space, get you that luminal gain, that's not arthrectomy, is really a game changer. And so with that set up, I want to hand it over to my next colleague.
So next we'll hear from Mike Sia. Mike's going to show us some cases.
Hi, everyone. Happy to be here. So I've got a few cases that show the versatility of this technology for below-the-knee lesions, and I think this first case is pretty significant in the wake of the BEST CLI trial results. So This is a 64-year-old gentleman who previously had undergone a left common femoral to posterior tibial artery bypass with PTFE a year before. Bypass was performed for a non-healing wound, subsequently healed, but on follow-up for routine surveillance, distal to our anastomosis, we detected a high-grade stenosis of the posterior tibial artery, seen here. So you can see a very, very focal, almost 99% stenosis of this bypass, or of the posterior tibial artery distal to the bypass. And knowing that we have a technology available that's superior to balloon angioplasty alone, you can see here a 3x80 serenator used to treat that lesion, and the balloon tracked up until the bypass. You see an excellent technical result. And especially knowing that this is going to be more durable than plain old balloon angioplasty, and I'm doing something different than people have historically done, I feel like I'm offering my patients a better therapy. And you can see that runoff down to the foot. This is another type of patient that we all see in clinic all the time. It's a 70-year-old patient with diabetes and CKD who previously undergone a partial toe amputation with a podiatrist because the podiatrist thought that the patient had palpable pulses down to the foot, and they had no idea that this patient wouldn't heal. So naturally, this patient was referred to our wound care center where arterial non-invasive studies were performed, and we could see that his ABI was 0.5 and his toe pressure was only 30 millimeters of mercury. So that's not consistent with healing. So took this gentleman for an arteriogram. You can see here, very focal, high-grade calcified lesion of the proximal anterior tibial artery, and his posterior tibial artery is occluded. Simple 4x40 serenator used right here. Excellent technical result. Post-interventional ABI went to 0.9 and his toe pressure increased to 80. So you feel pretty good after offering this patient this type of therapy. And then another case that we see all too often, a 60-year-old with diabetes and a gangrenous right hallux with palpable popliteal pulses, non-compressible ABIs, and a toe pressure of 20. You can see here a more complex arterial lesions down below the knee. His AT is occluded. His PT/perineal, not too sure what that is from this image, appears occluded in the mid-calf with reconstitution distally of that anterior tibial artery. And it looks like he has a posterior branch of the perineal that goes on to reconstitute his plantar vessels. So in this type of patient, I want to optimize their perfusion, so I opted to open up both. This is me using a 4x120 serenator balloon to treat that long tibioperineal trunk perineal artery, and then a 3x120 distally, as well as a 3x120 proximally. That's a pretty nice result with inline flow all the way down to the foot. And subsequent healing at 3 months with a toe pressure increase from 20 millimeters of mercury to 88 millimeters of mercury. So with that, invite Dr. Brodman.
So Mike, you get the award for the best pictures so far at a lunch symposium. But and probably some of the folks in the audience, if you don't do this kind of work on a day-by-day basis, it's probably a little bit challenging to actually to understand what these angiographic images are showing. But I think Mike summarized it well when he said excellent results in each of those cases. So, and I neglected to introduce Marianne Brodman. She's a friend to all of us. She was not allowed to travel from Austria, and she's made a short recording for us. So if you could go ahead and play that.
Hello, everybody. Sorry that I'm not able to join the VEITH meeting in person, but I'm happy that I can be part of this symposium, at least virtually. So what I'm going to say is, or what I'm going to tell you is about the prelude PTK study. When we compared the efficacy of the prelude PTK, or the serenator balloon, to a BOBA cohort. I have nothing to disclose with regard to this talk. So the prelude PTK study was, I guess you're all familiar with, a single-arm prospective multicenter study with atherosclerotic lesions in the infrapopliteal arteries and/or critical lymphemia, so Rutherford 3 to 5 patients. There was a call-up assessment with regard to angiograms, OCT, or IVUS, and the follow-up was up to 6 months, and the PIs were Dr. Andrew Holden and Michael Lichtenberg. So the primary objective endpoints with regard to the primary endpoints. The primary endpoint with regard to safety was a composite of major adverse limb events and perioperative death at 30 days. And efficacy was defined as the achievement of successful insertion, balloon inflation and deflation, and removal of the study device with a final diameter stenosis of less than 50%. And the device success will be evaluated on per lesion basis. And there was also a sub-study with regard to OCT and IVUS pre and post treatment up to 10 patients. These are the key secondary endpoints. And when we come now to the acute clinical results, we had the pre-diameter stenosis of around 80% and the residual stenosis after the treatment with the seronator of 21.8 plus minus 12.7%. So this was really amazing. And you have to have in mind, as you see here, that we have around 30% of patients with CTOs. And when it comes to bailout stent rate, there was only one bailout stent needed only one bailout stent placed. And also the subset analysis with regard to OCT or IVUS in Dan lesions showed a positive serration effect. So really outstanding results. And when it comes to dissections by grade, 69% of the dissections, so-called dissections, were either 0 or grade A or B dissections, so no severe dissections. The primary endpoint analysis, so freedom from primary safety event at 30 days, 95.7%. Efficacy endpoint, treatment success on dented lesions, 91.7%, and treatment success on treated lesions, 100%. When it comes to the core-lab-educated results at 6 months in below the knee, you see here the comparator trials, Biolux P2, Lutonix, Debate BTK, Impact T, Benangio Scalp. And when it comes to the freedom from clinical driven TLR, see how amazing it was with the preload PTK study, 97.7%, much higher than in all the other studies. With regard to final residual stenosis, much lower than in all the other studies with 21.8%. And then once again, I want to have a look at the really low bailout stent rate in the preload PTK study. So now it comes to the preload PTK sub-analysis study. This was standard balloon angioplasty versus seronator for the treatment of below the artery occlusive disease. This was a single center sub-analysis from the preload PTK study at our site. So when you have a look at this slide, we had 60 total lesions from the preload PTK study compared to 26 BOBA lesions. So we had 70 lesions from our side compared to 25 lesions which were analyzable from our BOBA cohort. And when it now comes to the direct comparison, final residual stenosis, BOBA at our side, 33.7% compared to 17.2% at our side. Once again, you also have to have a look at that. The number of CTOs was much higher in our preload cohort than in our BOBA cohort. So this really efficient achievement of final restenosis, which was so low with a higher degree of CTOs, and no bailout rate, neither in the preload nor in the BOBA study. And once again, I want to have a look at the average pressure BTK arm, 5 atmospheres compared to the 9 atmospheres in the BOBA arm. So we had to conclude a 49% improvement in final residual stenosis compared to the BOBA arm. With regard to hemodynamic flow results for non-CTO, the seronator achieved greater than 2 times the average flow rate than BOBA in non-CTO lesions. And when it comes to the BOBA arm, the seronator achieved greater than 2 times average efficacy in restoring flow than BOBA in the CTO lesions. So just let me conclude. Using the serration technology improves lumen gain over BOBA as assessed core lab, but also the serenader was able to achieve greater than 2 times the average flow rate ratio than BOBA in non-CTO lesions and 2 times in CTO efficacy in restoring flow. Thank you very much for your attention.
Yeah, so I've been several times to visit University of Graz in Marianne's lab. They are doing so many studies and they get to evaluate so many devices. And she had used the Serenator a number of times and she kept saying, wow, this lumen looks so great. And then she came back with this idea, hey, let's study it. Let's look at plain balloon versus serration angioplasty below the knee. And as Anahita said, we don't have that many tools for below the knee. We're mostly doing POBA, sometimes preceded by atherectomy, sometimes not, but it's mostly POBA. So this chance to see, and this difference in residual stenosis from around 30% after plain balloon versus less than 20% with serration angioplasty, we think of that, we want the residual stenosis to be as low as possible, but when you convert it to flow, since flow is proportional to the radius to the 4th power, actually diminishing that residual stenosis probably has a big impact. So with that, let me just call up Dr. Raman Sharma, who's from New York here at Mount Sinai, and please give us your wisdom here on this.
All right, guys, thanks for having me. It was a short trip from uptown, but these are my disclosures. So we're just gonna jump right in. I have 2 cases. We'll see if we'll be able to get to both of them. But the first is a 69-year-old female. She has the very common risk factors. She had some pretty advanced work done to aortic arch because of a penetrating ulcer. Had an interposition dichron graft to these common and external iliac the year before. And she basically came in with severe lifestyle limited claudication, or left worse than right, on all the medications and positive ABIs, and her aortic duplex showed bilateral SFA CTOs. So unlike Michael, I don't have any pictures of feet or toes, but I just have a bunch of angiograms of DSAs. So you see on the right side that long SFA segment CTO. We'll see if this will also play some pretty, normal tibial vessels. Here's an iliac angiogram with that interposition graft. And on the left side, you see a very long segment CTO of the SFA reconstituting at the distal SFA proximal pop, and has some pretty well established tibial vessels. This was a kind of a unique case because there really was no proximal cap to really begin, which then will kind of explain how we chose to approach this case to cross. We tried all of our typical antegrade techniques and didn't really fly too well, and we see the distal SFA is actually quite healthy. So in this case, we went with a direct SFA axis that showed that was the cross here. And after the cross, began by just doing some pre-dilatation with a 4.0 balloon. The cross itself was quite straightforward. This is one of those heart rate rings, so you can see all the chips in there. Yeah, no arthritis. And this is after a pre-dilatation with a 4.0 balloon. The 5.0 Serenator 120 we did to the distal, mid, and proximal SFA. And really just a remarkable result after just the atherotomy alone. It almost looks as if there was no disease ever to begin with, which was initially I was a little hesitant to have this be the destination therapy, but this was a very good result all the way to the distal vessel. And we underwent, did some DCB with a 60200, tacked up the proximal and the distal edges with a 6.0 Zilver. And again, just a pretty remarkable result for a case that would have otherwise been quite complex. Let's see if this last one plays. Yeah. And you see, there's also an IVUS run, which unfortunately I wasn't able to really incorporate into the slides, but I assure you looks just as good as this. The next case we have is a tibial case. It's a 74-year-old male, again with the same risk factors as ischemic cardiomyopathy, had a MI in the past with progressive claudication. That in the past 3 to 4 months has kind of progressed to ischemic rest pain. Again, on all the medications, diminished ABIs bilaterally. And on his arterial duplex, he had severe bilateral multivessel tibial disease. So I'll just focus on the right here. He has some moderate lesions in SFA, which didn't have any significant gradient on pullback. And then on the tibial DSAs, you see that the peroneal is a dominant vessel going down to the foot. The AT has some multifocal disease with a CTO segment in the mid, as well as a PT that seems to be the more robust of the two, which approximately, again, has some disease. And in the mid segment on the right, you see is a pretty long CTO segment. So we began by doing the same concept, doing a little bit of pre-dilatation to help identify the vessel a little bit better and get some of the other devices down. We did a little bit of atherectomy with the directional system. Then went with the 30120 serenator all the way to the distal, which initially in our practice we started to incorporate doing a little bit of pre-dilatation to help get this device all the way down. Which over some other techniques that can be used to help it get all the way down. Then do this 3.0 serenator all the way up. And after the serenator, just an absolutely astonishing result, and no stents needed, all the way down to the foot. Thank you.
No, very good cases, and a little bit of a switch there to SFA. So the next talk is going to be by Ted Gifford. Ted has been interested in the use of serration angioplasty for not just below the knee, but below the ankle. So now we're moving into the pedal circulation. And of course, if we don't have very many tools for below the knee, we definitely don't have many tools for the actual foot arteries. And Ted, please take it away.
Thanks so much. I want to thank Dr. Schneider and Cagent Vascular for inviting me to present some of the difficulties in treating distal tibial and pedal atherosclerotic disease as it relates to CLTI. I think that all of the panelists today have really touched on some of the unique features of this technology and why we think it's so helpful and has such promise in this area. I'm going to start with a brief outline of a case that I think highlights this problem well. This is a 65-year-old male with poorly controlled diabetes who presented with first toe gangrene, adjacent second toe digital gangrenous changes, cellulitis, and systemic signs of sepsis, including leukocytosis. On exam, patient had no palpable pedal pulses. They did have a weak monophasic PT Doppler signal. So we were consulted to evaluate this patient. We proceeded with an angiogram. Essentially, those findings are significant for multifocal eccentric stenoses within the perineal artery proximally. You can see that the AT artery occludes immediately distal to the origin, and the PT is patent but diminutive throughout with some small stenoses proximally. When we look down at the foot, we see that, in fact, the AT and the PT are occluded. The common plantar is also occluded, and via unnamed collaterals from the perineal, you have some filling of the medial and lateral plantar vessels as well as the distal DP. So what are our treatment options in this patient? I feel like this patient is already a setup for difficulty. They have, based on Wi-Fi, a wound class of 2 and an infection class of 3. So even without this vascular disease that we see present, they're a clinical stage 4, very high risk for amputation. We can consider doing a distal bypass. However, there's both active cellulitis in this case, as well as if you look at these targets, some of my other colleagues, Leanne O'Banion comes to mind, she'd probably go after that lateral plantar, but I don't know that I would. I think I'm looking for more robust distal PT targets for tibial bypass. So I think this is a patient where endovascular therapy might be able to help them, but as has been pointed out, there's really not a lot for inframalleolar treatment, right? Most of the studies that we've seen done reflect the use of plain balloon angioplasty. There's been some work in concomitant atherectomy, but oftentimes this is used as a delivery mechanism to allow us to deliver definitive therapy. Certainly, stents are unlikely to have any durable outcome and would not be advised in this area. I'm going to touch on 2 trials that looked retrospectively at the outcomes of pedal artery angioplasty. The first is a cohort of about 250 patients that was propensity matched one to another, all with pedal artery disease. And they essentially compared patients with pedal artery disease without attempts at intervention and patients with pedal artery disease that underwent attempts at angioplasty. And they found that in that cohort, technical success was quite low, which I think underlies the problem with this as a general rule. It's difficult to be able to successfully treat these patients. Their technical success rate was 60%. However, they found that in patients that were successfully treated, they had improved freedom from major amputation at 1 year and improved time to wound healing. A similar study of the Rendezvous registry cohort, patients with pedal artery disease with and without angioplasty, found that the use of angioplasty was associated with an overall improved rate of wound healing and decrease time to wound healing. And so I think this reflects the fact that, our patients don't just have arterial disease, they don't just have comorbidities like diabetes, they have wound problems that require a durable option to get the blood flow all the way out to that distal vasculature and help them heal. And I think that Dr. Dua touched on that really nicely. So with that in mind, let's return to the case. I started with the peroneal artery intervention. So this was done with a 3mm serenator. I sized this based off of IVUS, crossed without too much difficulty, and inflated this to subnominal pressure. So at 5 atmospheres, you can see a really nice luminal expansion in that peroneal artery. With repeat IVUS, to Dr. Broadman's point, there was really very little residual stenosis, no recoil, no dissection. So patient did well there. Given the fact that they didn't have a named collateral vessel, that communicating branch from the perineal really didn't go into the plantar, and the common plantar itself was occluded, I was able to get down into the distal common plantar, and then because of the long length of the PT occlusion, this is definitely a case where I would predilate. I think trying to track that balloon down de novo is a little difficult, whether or not you use atherectomy in your practice to help deliver some of this technology. We were able to get a 2.5 by 120mm serenator down about 2.5 centimeters into the common plantar artery, and again, just at nominal pressures with 6 atmospheres for 3 minutes, you can see that this is the completion result. And very, very brisk flow afterwards throughout the recanalized PT, common plantar, and out through the lateral plantar artery. So what are some of the advantages of using this technology in the pedal space? Well, for one, we can achieve such good luminal diameter at very low pressures, all right? So I think the risk of vessel trauma, whether dissection or rupture, is very low. In addition, we have prolonged patency. So if we extrapolate some of the results of the Prelude BTK trial, you know that the freedom from CDTLR is profound. And as I mentioned in some of the other studies, these patients don't just have an artery problem, they have a wound problem. So whatever we do, we want it to be durable. And I think that, again, by achieving that really nice luminal gain, by decreasing the residual stenosis, we're helping to improve long-term patency. And finally, as has been touched on multiple times, there's really nothing else in this space, all right? So plain balloon angioplasty may just kind of push stuff out of the way. I don't think it remodels plaque in the same way. What are some of the challenges? Well, vessel diameter. The smallest balloon we're going to use is a 2.5. Now, as Dr. Sia showed, he's using 4mm balloons well down into the perineal artery. So I think that the fact that we're doing this at very low pressures is what minimizes vessel trauma. Tracking to the vessel. So I do think that adjunctive technology helps here, whether it's plain balloon or atherectomy. Sticking antegrade on the common femoral to improve your pushability. These are all things that are, I think, vital in terms of improving your rate of technical success. And lastly is patient selection. So you want to be cautious about who you use this on. Obviously, bailout options below the malleolus are limited. So to summarize, this patient was successfully treated. They were sent out on clopidogrel and apixaban for their atrial fibrillation. You can see their non-invasive studies when they got into see us in clinic show excellent preserved waveforms. This is over a year after their initial treatment, and they were able to heal that first toe amputation without any need for reintervention. To summarize, I think the application of the serenator within the pedal vasculature is promising. I think we need to look at this a little more closely to be able to determine how best to utilize this technology in this space. Again, I want to thank Peter and the rest of the panelists, and I want to thank you all for joining us today.
And Ted's currently involved in a study of pedal angioplasty using serration, so that'll be exciting. Anyway, so when I introduced the panel, I think I said they were rising stars. I think maybe that's wrong. They're probably stars now. Anahita, Ted, Rahman, and Michael. But Michael Lichtenberg has also joined us. And Michael, it's like the beginning of the James Bond movie where the guy parachutes in wearing a red. Anyways, he just landed at JFK like an hour ago and somehow managed to get here. So we're really pleased to have him. He's, in my opinion, probably one of the most famous interventionalists in the world. Everybody in the interventional community knows him. So Michael's going to add his 2 cents next. So thanks, Michael, for making the effort that it took to get here. His first flight was canceled. So we had this whole I can't explain how many texts and emails were involved in figuring out how this was going to be managed. So.
Yeah, thank you very much. Pleasure to be here. Thank you very much for the invitation, and sorry for the Lufthansa mess here, but fortunately I made it. Singapore Airlines is a good airline. Yeah, they saved me here, so just to say that. So a little bit of case series of this device, which we now have the possibility to use for a couple of years, and I don't know how many hundreds of devices we already used in BTK disease. You probably discussed already about the issues below the knee. I think it's clear these are the objective. We are talking about a very complex morphology, long diffuse vessels. We are talking about heavily calcified vessels. I think that's all clear. And long CTOs are the standard, I think, nowadays. We learned that early recoil is an issue, and Frank Baumann already told us this a couple of years ago. Recoil is probably there after a couple of minutes after standard balloon angioplasty. So standard balloon angioplasty in my labs is over, actually. This time has been over because this is what you see after 50 minutes. You see a recoil, and you could definitely imagine what that means for wound healing in these kind of patients. So let's dive into some of the cases we did. So this is a case, Rutherford 5 patient with an occlusion of all tibial arteries. You see here an occlusion around the malleus. Perfect indication actually for the serenator. We used here without predilatation 2.5, 122 open here, this distal tibial posterior artery into the plantar artery to hopefully get wound healing afterwards. And this is after the result after 2 minutes, as you could see here, straight line to the plantar arteries. No dissection, no recoil, no significant signs of barotrauma. Just 4 atmospheres, done. Yeah, imagine what could have happened with the standard balloon angioplasty with 10, 12 atmospheres. Dissection, recoil, etc. And I think that is what we are talking about, low barotrauma, no harm to the vessel. And this is the next one, which we just treated a couple of days ago. Pedal artery, we just saw a great case. There another pedal artery example here of a branch of the dorsal pedal artery in a Rutherford 5 patient. Here, without predil, serenator, 2.5 millimeter. And you could see here in the dorsal pedal branch here after 2 minutes, no significant dissection, very good lumen gain. And lumen gain, I think that is the important aspect. I think we have 2 mandates. To open the vessel, I think it's clear. But to maintain patency, this is, I think, our most important job now, when we have to find solution that to keep vessels open. It's not all about make vessels open, it's about keep vessels open, and I think that's a typical example. Another case here, also just recently done, last standing anterior tip artery in a Rutherford 5 patient, high-grade stenosis for the anterior tip artery. Also here in this case, we use a 3.0 millimeter serenator, short 40 millimeter. As you can see on the left side, this was a live transmission, actually just 4-5 atmospheres without predilatation, and this was actually the final outcome done after 2 minutes inflation. So I think 2 minutes inflation, that is the important thing. Good lumen gain with the 2-minute inflation. You can discuss about DCB afterwards, but I think the important aspect to avoid barotrauma. And I think that is the issue why all these DCB trials failed, because nobody really cared about the barotrauma issue after DCB, about the recoil, about the dissection. This is probably one of the important aspects. So the next step would be to combine serration angioplasty with DCB versus non-DCB. Would be very interesting to see. I would probably think that there is no significant difference because you're avoiding barotrauma, you're avoiding dissection. I think that is the most important aspect in these Rutherford 5 patients. Thank you very much.
So whenever I got to go to Arnsberg, Michael always had a live case going on, either right before or right after. He has a whole raft of people that are there to watch him work and that sort of thing. And so that's some of what he's showing you here of a live case transmission. So do we have any questions from the audience? We heard a lot about it, the mechanism of action, how it's being used. If you do have questions, please chime in. I see one in the back.
How well does it work for really heavily calcified vessels? Because that's the biggest problem in your dialysis patients. That the vessel wall is just you got craters in there. And how well does that work, versus just regular stuff that we have rack here in the combination?
Yeah, good question. Anybody want to tackle that from the?
So I'll just say, of course, my colleagues will speak to as well. Can you hear me?
Yes.
Yeah, good. Okay. No one ever says no. So the interesting thing about this is the way I envision it is basically they're like pie crusts that are made inside the plaque that's within these diabetic vessels. And that's really my mainstay. I do a lot of diabetic legs. And in those patients, the issue is really twofold. One, even if you get a wire across, you can't cross anything beyond that. And then the second thing is if you do cross, like what we were talking about before, that bearer trauma aspect, that, you know, you get like pillows of the balloon popping up in one area before it really aggressively will pop in that space that's the tightest. And that's where you get the dissection, and then you get the, you know, it's going to thrombose and you're not going to get what you need. But what this does is just like, first of all, the crossing is excellent because it's meant to be, you know, very low profile. And then you get that little like serration that's made within the plaque. And then if you come back, now that you've got some luminal gain, if you've got to go further and put up a POBA or a DCB, you know, which is ideal, then you can really get good stretch out of there. It's very similar to like skin grafting and making cuts in a skin graft and how you can like stretch a tiny piece of skin so far. It's the same kind of concept. And so I found it to be very helpful, actually, and not at all detrimental to the vessel.
And one other data bit that's helpful, and then we'll come to you, Mark, is that in the Prelude study, which was our above-the-knee study, we looked at the core lab adjudicated calcium levels in the lesions. And what we found was that the heavily calcified lesions were dilated at relatively low atmospheres of pressure. So consistently, we're able to get a good lumen at 4 to 6 atmospheres, as opposed to the usual plain balloon story of 8, 10, 12, et cetera. In fact, now there are a number of folks working on the idea of super high pressure compliant balloons, you know, to try to get the lesions to yield. Whereas here, the way the lesions are yielding is we essentially created a kind of a cut along the dotted line. So we know from physics that your energy is directed. It's either going to be directed randomly or it's going to be directed along a specific plane. And that's really what we're doing here. Mark, question.
Yeah, it's actually more of a comment just on the first comment, question and Dr. Dua's answer. You know, as you know, we use it a lot in our hospital setting, and we have a heavily calcified diabetic population. The comment is that there are cases that it is challenging to get across the heavily calcified, very occlusive disease, and sometimes you just need to pre-dilate to get the balloon to go. However, the positive comment is that if you have a chance to go by the booth, they've now adjusted the tip so that it's tapered exactly to the wire. It's much more sleek than the original version, so I think that's going to help a lot to deliver it without having to pre-dilate.
And I have a question for Michael. Do you have any jet lag? No, I'd like to know, since you've been using this for a long time, you've been using it in multiple vascular beds, how do you fit this concept and this tool into your algorithm, your day-to-day algorithm?
So as already stated, so it replaced in many cases standard balloon angioplasty. Yeah. Because also not only from a clinical point of view, and what was just mentioned, if you have a lot of barotrauma, dissection, recoil, etc., it means that you need out bailout strategies like stenting, like tacking, whatever. If you take this in economic consideration, that means that you have some extra costs for that. Avoiding that, just bringing a special balloon down there, avoiding all this, and you're done with the case. I think that's also a very important aspect, and therefore we replace in many cases standard balloon angioplasty, especially in, as you just said, the calcified vessel. And it's true, of course, sometimes you need to pre-dill 1 millimeter smaller. I think that is clear, especially in calcified lesions. That could happen. Yeah.
Yeah. So one thing that we have seen is, we track some of the usage, clinical usage in the U.S. and below the knee, it's mostly being used as standalone therapy, and above the knee, it's very often being used prior to some other definitive therapy, typically drug-coated balloon. But it also could be used prior to other kinds of stents. For example, if you were intent upon a drug-eluting stent or a woven nitinol stent, where the adequate vessel prep is of high concern to get the proper deployment and the excellent result. So. And then, so for Ted, with regards to pedal angioplasty, you showed a couple of really nice cases. Prior to the use of Serenator, is that typically a plain balloon case then, some of those couple cases you showed?
Yeah, in my practice, I don't do a lot of really distal tibial vessel prep with atherectomy, so it's really about getting something, and I think to the point that's been made multiple times, in these patients with circumferential medial wall calcification, you know, even a POBA, you blow that up, it doesn't really do anything. The recoil, especially down in the pedal space, is just, it's almost immediate. And unfortunately, as a young clinician, I was kind of waved off a lot of pedal artery intervention because I think people that had come before had done too aggressive dilation with POBA and caused barotrauma, caused, you know, dissection, and then very soon thereafter vessel thrombosis. And I think that, you know, with this, it just is very, very, I'd say gentle, but focused. I use that analogy of the granite that Peter brought up before. I really think that hammers the message home, no pun intended. But, you know, it is all that focused energy as opposed to just indiscriminate high-pressure balloon angioplasty.
And Michael, you've mentioned before that, or Michael Sia, you've mentioned before that the kinds of, so you're in Texas, you're in the south part of the country, it's a little bit different demographic. How does the BTK disease vary there, say, versus in other places?
So I trained in Washington, D.C., which is a very different ethnic background or ethnic group there. But I would say that in Texas, there are large populations of underserved Hispanic patients, and they have very, very advanced disease, and they oftentimes present for the first time with Rutherford 5, sometimes even Rutherford 6 peripheral arterial disease. So having something that I can use quickly to take care of these patients and know that I'm going to get a durable result that's superior to historical tools that we've used is really nice, because not only does it allow me to effectively take care of patients, but it also allows the podiatrist to do definitive therapy and get these patients out of hospital sooner, which I think lessens the burden on overall healthcare systems.
Yeah. Yeah, Dave.
Just got a question about the design. Is the diameter of the devices just the balloon diameter, or do you add in the diameter, the additional diameter from the serrations? And then if you don't, how do you kind of choose a vessel diameter to ensure that you're not overdilating?
Yeah, so that's a good question. I mean, we have so much focus now on getting the balloon properly sized and not just using angio alone and measuring the actual diameter. And what we're typically doing is going by the diameter of the balloon itself. The serrations are intended to enter the wall and to dig a little deeper than where you see the lumen. And I think this is part of the issue, is that I think unless we reach the internal elastic lamina in the least injurious possible way, you can't really open the artery in a way that you really intend. And I think this also is why we're seeing, you know, it's early yet, but we're seeing some reduction in recoil as well. So if you think of a sausage casing, if you never really cut the casing, you know, you can stretch it, but it just springs back to where it was. So we're typically recommending a 1:1 or 1.1:1 balloon to artery. Yeah. Anyways, with that, we should go. Thanks everybody for coming. That was awesome. Michael, thanks for parachuting in.